بسم الله الرحمن الرحيم ورمضان مبارك على الجميع. Our lecture today about diabetes mellitus in pregnancy. Diabetes mellitus is a metabolic disorder of multiple etiology characterized by chronic hyperglycemia result from defect in insulin secretion. It is considered the most common medical complication that could affect pregnant patients. Regarding physiological changes, typically glucose is spared for fetal consumption in pregnancy. This will lead to a fall in fasting blood sugar. In contrast, for a carbohydrate meal, the level of glucose is higher than in non-pregnant patients. Thus, during pregnancy, we have transient maternal hyperglycemia after meal, mainly because of increased insulin resistance, and hypoglycemia between meals and at night because of continuous fetal draw of glucose. During pregnancy, diabetes could be pre-existing type 1 or pre-existing type 2 or gestational, that is to say, occur for the first time during pregnancy. As a generalization, it is the degree of maternal hyperglycemia that influences the fetal outcome, while it is the type of diabetes that could affect the maternal outcome. Outside pregnancy, the diagnosis of diabetes is made by classical symptom of diabetes, which is shown in this photo, plus casual blood sugar of equal or more than 11 millimole, fasting plasma glucose of equal or more than 7 millimole, 2-hour plasma glucose of equal or more than 11 millimole during oral glucose tolerance test, or by hemoglobin A1C of equal or more than 7.5. Diabetes could have complication on the mother and the fetus and the newborn. Regarding maternal complication, increased risk of diabetic ketoacidosis and severe hypoglycemia. There is a risk of worsening microvascular disease, coronary artery disease, hypertension, nephropathy, retinopathy, and neuropathy. Preeclampsia is 3 times more in diabetic than non-diabetes. Increased risk of recurrent vulvovaginal infection, incidence of operative delivery, obstructed labor, urinary tract infection is more common in diabetic patients, polyhydramnion and birth trauma, and postpartum infection. Fetal complication, perinatal death before the use of insulin was higher than 50%, but now the rate is under 5%. Congenital abnormality is 2 to 4 times more in diabetic than non-diabetic, especially neurological and cardiovascular, a 3-fold increase in diabetic patients. This is a caudal regression syndrome, hypoplasia of the lower limb, and agenesis of the sacrum. It is a pathognomonic that the women have diabetes. It is 200 times more frequent in infant of diabetic mother. Regarding fetal complication, maternal hyperglycemia will cause fetal hyperglycemia, and this will stimulate the pancreas of the fetus, lead to hyperplasia, fetal hyperinsulinemia, and this will cause macrosomia, organomegaly, polycythemia, hypoglycemia, and RDS. Increased risk of miscarriage, mainly due to congenital abnormality, preterm labor, RDS, stillbirth. It is 5 times higher in baby of diabetic mother. Increased risk of trauma because of macrosomia and shoulder dystocia. Fetal macrosomia occur in around 1/5 of diabetic pregnancy. Neonatal complication, jaundice, polycythemia, tetany, hypocalcemia, hypomagnesemia, and hypoglycemia. Management of pregnant complicated by diabetes. The ideal approach is to start management before pregnancy. The aim of pre-pregnancy counseling is to achieve the best possible glycemic control before pregnancy and to educate diabetic women about the implication of pregnancy. The patient should have a detailed history, physical examination including ophthalmological examination, ECG for women 35 and older and smoker, and kidney should be checked before pregnancy. Patient should be instructed in the technique of home monitoring of capillary blood glucose, and control should be good before try to be pregnant. Control is checked by hemoglobin A1C should be less than 6.5, fasting blood glucose should be less than 5.3, 1 hour post glucose load should be less than 7.8. Patients who are not achieving this target should discourage from being pregnant. Folic acid 5 mg should be given for at least 3 months before pregnancy and until 12 weeks of gestation for the prevention of neural tube defect. How about oral hypoglycemic agent? If the woman was type 2 diabetic and was already on oral hypoglycemic agent, if she is on metformin, okay, she can continue on it during pregnancy or together with insulin. For women not using metformin, it is best to shift to insulin. We should stop angiotensin converting enzyme inhibitor and angiotensin 2 receptor antagonist and consider alternative antihypertensive like methyldopa or labetalol. And we should stop statin. Contraindication to pregnancy: if diabetic patient have ischemic heart disease, if she had untreated proliferative retinopathy, or if she have severe renal impairment. Now we come, what is the specific management for diabetic patient during pregnancy? First appointment, she should be cared by joint diabetic and antenatal clinic. The patient should be seen by physician, obstetrician, and dietitian. We should offer the patient information and advice and support in relation to optimizing glycemic control. Early in pregnancy, at 7 to 9 weeks, she should have ultrasound to confirm gestational age and viability. Dilated retinal examination should be performed, as we said, before pregnancy and early in pregnancy, and again at 28 weeks. Renal assessment should be arranged before pregnancy, first contact in pregnancy, and if renal function test is abnormal, referral should be done to a nephrologist. Advise pregnant with diabetic to take aspirin in a dose of 75 mg daily from 12 weeks to delivery unless it is contraindicated. Additional investigation: she will need hemoglobin A1C in each trimester, booking investigation for thyroid function test, urea electrolyte and liver function test, urine for albumin creatinine ratio. Screening for congenital malformation at first trimester by nuchal translucency, at second trimester by anomaly scan at 18 to 20 weeks. At 28 to 32 weeks, offer ultrasound monitoring of fetal growth and amniotic fluid volume. Regarding fetal well-being or fetal surveillance, we should inform the patient about the need for fetal kick count, periodic fetal heart monitoring or NST, intermittent biophysical profile. This should be begin at 32 weeks and occur at twice weekly until delivery. At 34 weeks, we should consider admission for insulin treated women. While in the hospital, they should continue daily fetal movement count and undergo fetal heart rate monitoring 3 times a week.